Delighted to have with us a Duke Blue Devil here at ASCO 2012. He is Daniel George, MD, Associate Professor of Medicine and Oncology. Thanks for being with us.
Thank you, Thomas. Pleasure to be here.
So you're here to talk about kidney cancer treatment and unmet needs. You presented on this, and there were three questions that you really looked at. What were they?
Yeah, Thomas, I think this is a great time in kidney cancer. In the last 7 years, we've made tremendous progress with the addition of 7 new therapies. But despite that, there's several really critical questions, I think, for the practicing clinician now in the field today. First off, for the majority of our patients that are starting on a VEGF receptor tyrosine kinase inhibitor that are going on to progress, 20-30% of those patients will progress right away. Most of those patients will progress within 2 years. What's the mechanism driving that disease progression? How do we overcome that? How do we add to it? Second question is we're seeing lots of tumor regressions, but very rarely do we see a complete response, a real complete disappearance of the tumor. We do see it, but it's rare. How do we increase that number? How do we get to more complete responses? And then the third question, kidney cancer is not one disease. There are subtypes of kidney cancer, papillary and chromophobe. For those rare, less common histologies, what are the treatment approaches that are going to be most successful? So those are the three questions I kind of focus on as sort of today in 2012, what are still the areas we need to make progress on?
What can you tell us about some of the specifics of the data you presented?
So first off would be those mechanisms of resistance. I really kind of broke it down into 3 areas based upon what we know from preclinical studies and some of our clinical observations, mostly around prognostic factors and predictive biomarkers. So the first is a mechanism of resistance where perhaps we're just not blocking the VEGF receptor pathway enough. It may be because the drugs are not well tolerated, there's dose reductions or interruptions, and maybe because the agents we're using today are not the most effective at blocking this receptor. Some of the newer generation drugs like Tivozanib and axitinib that have much higher affinity for the VEGF receptor may be more effective if the mechanism of resistance is that we just haven't been able to block this target enough. The second mechanism might be that we're inducing pathways independent of VEGF that are driving angiogenesis. So the biology of growing new blood vessels or angiogenesis may be purely VEGF driven or it may not be. And if those mechanisms involve other targets, then adding separate targets to the VEGF pathway may be a second mechanism to overcome this. The third mechanism that I think I'd be most concerned about are tumors that are able to grow in low oxygen, what we call hypoxic environments. Those tumors have the ability to change and progress in that setting where perhaps angiogenesis strategies are going to be completely inadequate by themselves. So recognizing there may be different types of resistance, not one size fits all for that in the future. Biomarkers really give us a clue into which of these may be happening. In some cases, we may see elevated VEGF levels that are very high being generated by the inhibition of this pathway that's driving that resistance. That would be sort of mechanism number one. Second would be biomarkers that go up when we block VEGF like IL-8 or hepatocyte growth factor, the c-Met ligand. Those pathways may suggest we need to add a separate target to the VEGF inhibition. And then the third would be signals like epithelial mesenchymal phenotypes like sarcomatoid or other sort of genomic profiles of tumors that have the innate ability to grow in low oxygen states. Those would be sort of the predictors of that third worrisome, as yet kind of untargetable biology of resistance. So that's what we know kind of in a nutshell on those 3 areas.
Now you also had some involvement with the TiVo-1 trial.
I did.
What would you like to say about that?
Yeah, I think, I was involved in some of the planning and the steering committees leading up to and carrying through and analyzing this data. And I think recognizing today, even though we have a number of VEGF receptor tyrosine kinase inhibitors, for a significant portion of our patients, they're not able to tolerate full dose chronically. And I think what Tivozanib really represents is a therapy that has very, very high affinity for these receptors, much higher, logs higher than what we see with some other drugs in class, and great specificity. And what's really encouraging about the results is that not only do we see excellent progression-free survival, a statistically significant improvement compared to our historical controls with other therapies and head-to-head against another active agent, sorafenib, but we see great tolerance and tolerability of this agent in this patient population for a long period of time. And it really suggests to me that this is a drug that might translate into community practices really well, where our patients might be older, more frail, dealing with other comorbidities than our clinical trial population. So I'm really encouraged about the ability to take an agent like this and apply it in a broader population of patients.
For kidney cancer patients, you feel that they have a need for something effective, but you've used the word a few times. They really need something that they can tolerate.
Yes, yeah. I think that this is a chronic disease now. Patients are living probably twice as long as they used to with this disease. And what's really important is the quality of life on therapy, because it's not sort of a treatment, then you stop. We're really talking about treatment indefinitely. So how you maintain that, not just the maximum tolerated dose, but a really tolerable but still effective therapy. And I think that's really kind of where this drug really fills an important need in the future. I think some of the other things we want to be able to get to are complete responses. And I mentioned that's rare. Drugs like Tivozanib may give us the opportunity to add second or third targets to this. So if it turns out that blocking VEGF is important but not complete for angiogenesis, and we need to add a second or third target, we need a base, we need a compound that we can build off of that has really good tolerability and can combine with other agents that is fairly clean in its profile of toxicity. And I think that's what we see with this agent. So I'm excited both in using it as a single agent, but also in some cases being able to do combination studies in the future.
Thanks for stopping by, Doctor. I love your passion. I can tell you love what you do to try to help patients.
I appreciate that, Thomas. We'll keep it going.
You got it.
Thanks.
Dr. George from the Duke Cancer Institute joining us here at ASCO 2012.